So, hello everybody, and thank you for making time to join us for another one of our Meet the Specialist sessions with the lovely Dr. Loretta Reiter. Dr. Reiter is a rheumatologist, and those are people who specialise in musculoskeletal medicine and things like fibromyalgia. They're also often involved with sports medicine and sometimes with older people, geriatric medicine at times. It's a really interesting specialty. Now, at MAG, we've worked with Dr. Reiter for many years and we love having her with us. She writes an excellent report and is really knowledgeable and highly respected in her field. Now, I'm going to ask if you can all keep your microphones muted while Dr. Reiter is talking, but towards the end, there'll be a chance to ask a couple of questions if you'd like, and you can unmute yourself then. And at the end of the session, the recording should come out to you within about a day or so. So without further ado, over to you, Dr. Reiter. Thank you.
Thank you, Michelle. That was a lovely introduction. Hi, good afternoon, everybody. Yes, I'm a rheumatologist and I have been so for close to 30 years. Kind of gives my age away, which I don't always like, but anyway, it is what it is. And I have a lot of experience, and I like to think of rheumatologists can do anything an orthopedic surgeon can do, plus more, because we actually are very good diagnosticians. We're really good at making a diagnosis and then instituting the treatment for that. So I would see anything an orthopedic surgeon would see, and I would make the diagnosis, institute the conservative treatment, and then if treatment failed and then thought surgery was an option, send them on to the surgeon. Whereas surgeons, their main function is just to decide yes or no to surgery. These are the outcomes. This is what you can expect. So in that regard, I think we have a little bit of an edge on orthopedic surgeons. And so I would cover anything that's musculoskeletal, including osteoarthritis, anything to do with the joint, anything to do with the tendon, anything to do with the bursa. We even cover areas such as peripheral nerve lesions like carpal tunnel syndrome, ulnar neuritis at the level of the elbow, radial tunnel syndrome, lateral epicondylitis, all those sorts of issues, and even spine. I see spinal pain and I see nerve root impingement, and I'll do conservative treatment. So, for example, somebody presents with, a lesion or a pressure on a cervical spine nerve or a lumbar spine nerve. I refer them for a CT guide injection of cortisone, which can completely resolve it. If it doesn't, then send them on appropriately to mostly a neurosurgeon, but there are, as you I'm sure well know, there's a few orthopedic surgeons who have a special interest in that, and including facet joint injections. So we deal with pain, and so that's on that side. But on the other side of it, we actually cover very broad areas that like rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, which are autoimmune conditions. There's even things like vasculitis. So, and that involves having a really good understanding of the whole body, because those conditions can affect other parts of the body apart from the joints and the tendons. And with those, I'm now working in an era which is just absolutely amazing for those conditions, because we have these drugs that cost $20,000 per year, but the government will pay. In this country, we're so fortunate, the government will pay that money based on certain criteria, that they fail drugs that we know they're cheaper and can work. So it's just wonderful. So unlike when I did renal medicine as a registrar, professorial registrar for a few years, and the professor of renal medicine at St. George Hospital said to me, well, who want to look after a bunch of cripples? We're not looking after cripples anymore. She meant it jokingly because she wanted me to be a renal physician. But we now have these drugs that are just incredible. People come into my office and so disabled. Now we finally get them on that drug, and they come back and see me every 6 months, just because it's obviously paperwork because it's so expensive that has to go through. But that time I spend doing that paperwork, it's worth it just to see how well these people are. And as a rheumatologist, it's always important that if someone's not getting better, you revisit the diagnosis. You sit back, you take the history again, you do the examination again, and you go, right, now, have I missed something, or has something changed? Because things do change over time, they evolve. And I find that really, really, really important to do. Now, in terms of where I practice, I was practicing in Bankstown, but as of last year, I have closed my Bankstown rooms, but I still have my rooms in Dee Why, and that's where I see my patients. Otherwise, I do medico-legal work for MAG and others, I shall just say. No disclosure there. And I do travel interstate for those of you, but again, I do it for a specific company. I go to Melbourne, Canberra, and Adelaide. What else can I say? I love what I do. That's really the bottom line. And that's probably it in a nutshell.
Thank you so much. I learned from that because I didn't realize that the absolute breadth of what you do as a rheumatologist. And that really is incredible. And I think from the point of view of, in particular, insurance claims managers, if they're looking at a holistic outlook for a person and whether surgery is indicated, a rheumatologist should be your first port of call.
That's what I think. Yeah, I do. I definitely would consider that more than appropriate.
And do you, as a rheumatologist, see many people where their pain is actually as the result of surgery?
Oh, I see that more for medico-legal work than I would see it as a rheumatologist per se. So, for example, if somebody has failed surgery, there's not very much as a rheumatologist I can offer them. In that circumstance, I would say you need to go and see a pain specialist if surgery has failed them. But in terms of assessing their whole person impairment, if surgery has failed them, then definitely I have the ability to do that, because I'm work, if I can follow all these ones, I'm a part of the Personal Insurance Commission for workers' compensation. I've done work cover, New South Wales, Victoria, Tasmania, Adelaide. I've also done the training for motor vehicle accidents in both South Australia and New South Wales. And the other one is Comcare that I'm trained in. So I've got lots of those tickets to make all of those assessments underneath my belt.
Brilliant. That's really good. Now, people, attendees, is there anyone you would like to ask any questions? Please just unmute yourself. No,
whoa, that was too easy.
Well, I do have a question for you that came to me from someone who can't attend.
Sure.
And it's actually in relation to autoimmune diseases. And this person says that of their caseload where they have had people with autoimmune diseases, one of the things that they have noticed anecdotally is that a lot of those people end up gaining a lot of weight as the result of the pain they're in or the discomfort. And then it makes it harder from a medico-legal point of view to say the cause is this injury when the weight compounds it. Is that something that you find?
Okay, so if we're starting with the initial problem is that they have an autoimmune condition, which I would have to say is not work-related, because it's an autoimmune intrinsic constitutional condition. People will can not always do, because I've got lots of patients who do not put on weight, but we will treat them with prednisolone, which is an immune suppressant that works immediately. That one of the side effects of prednisone is weight gain, but that's basically how long you're on it for and how much you're on it. And a good rheumatologist will only use it in short bursts. Anyone who stays on it for long periods of time we aim to get it below 5 milligrams, because the side effects are very minimal under 5 milligrams. We aim to get it very quickly. So it works really well up front, because most of the medications that we use for autoimmune conditions take 3 months before we know they're effective. And so people, if they're suffering and not functional, then you would institute that. And I would start with a starting dose of 15 milligrams a day every morning for 2 weeks, then 10 milligrams, then 7.5, 5, 2.5, and ceasing it every 2 weeks. Now that should not put on a lot of weight. And if they're functional because of that, then they should be active. So because the other reason for putting on weight is not being active and in that circumstance. So it's a balance, and it's a balance of watching that. And sometimes general practitioners may keep patients on higher doses than they should. But I could tell you, any rheumatologist I know, we're all totally aware of that, mindful of it, and try and manage that appropriately. But it is possible, if not managed properly, is the bottom line, I guess.
Awesome. And look, the other question before I let you go is, when a person has an existing autoimmune disease, but then sustains an orthopedic injury, how do you go about the assessment and determining the whole person impairment when they already had that pre-existing condition? Okay.
So basically, for example, someone has psoriatic arthritis And that's under control with either a disease-modifying anti-rheumatic drug or the biologic, which is the $20,000 treatment. And then they have an injury at work. Say, for example, they have an inversion injury to their ankle. Now, the history in terms of pain presentation is very different on both. And that's how we determine as rheumatologists, is this inflammatory pain? Is this mechanical pain? And that's what I'm doing every time I'm seeing a patient when I'm talking to them about pain. And so I'll say to them, okay, so is the pain there 24/7? Yes. Okay. Is it worse in the morning? Yes. And does it get better as you mobilize? Yes. Is it stiff? Yeah. So when it's worse in the morning or when you're resting, so as the night goes on, it gets worse. That's what we call autoimmune inflammatory pain. It'll get better with mobilizing and often or may not be associated with swelling and stiffness. So they might say, well, how long is that ankle or that knee, for example, stiff in the morning? Oh, an hour, 2 hours, 3 hours, more than an hour, it's going to be due to an autoimmune condition. However, if there's evidence that they've had an inversion injury, there's evidence of an injury on an MRI, or for example, even there's maybe an anterior tibiofibular ligament tear, then you would have to look at the pain. The pain would be mechanical in nature. In other words, it's going to be better maybe not even present when they wake in the morning, and as the day goes on it will get worse. And so that then if they've got a reduced range of motion, that's going to be due to the injury, whereas if it's the pain on history is inflammatory, it's due to their underlying inflammatory arthritis, and that needs to be treated and corrected because they haven't been appropriately treated. And I would say it's not due to the injury.
Wonderful. Well, thank you so much. Everyone, thank you for making time to be with us for our Meet the Specialist series.
Thank you.
Thanks a lot, Dr. Reiter. The recording will come out to you within a day or so, people, and we look forward to you booking with this lovely lady and getting her excellent reports. Thanks a lot, Dr. Reiter. Have a great rest of the day.
Yep, you too. Thank you. Take care, Michelle. Bye-bye.